Welcome, everybody. We're just going to wait a few seconds to make sure everyone can join us from the waiting room. Welcome, everybody. We're just going to wait a few more seconds as people join us from the waiting room. Thanks for your patience. Okay. Great. We'll go ahead and get started. People may continue to join us from the waiting room. First, thank you for joining us for today's webinar, Cancer Screening and Prevention, What All Women Need to Know. I'm Sarah Keblin, the Communications Manager for the UVM Cancer Center. Before I introduce our speakers for today, there's a few housekeeping things I wanted to run through. Importantly, I want to thank our presenting sponsor, the Victoria Buffum Fund at the UVM Cancer Center, along with the Eleanor B. Daniels Fund at the UVM Cancer Center, as well as the very many of you who donated when you registered for this event. Helps us continue to provide free education across our region. So thank you. Our speakers today will be taking questions at the end of the presentation, and participants are welcome to submit those questions at any time using the Q&A function. You can do that anonymously or use your name. So go ahead and do that whenever you like. They'll get to as many of the questions as they can at the end as time allows. This webinar, as well as our other monthly webinars, are available on our website, vermontcancer.org. And we're excited to share that the full agenda for our October 2nd conference is now available on the website as well. We have a full day of virtual free learning on October 2nd. Check the website for more information. Great, I'm pleased to now introduce our panel of experts. Speaking today are Stephanie Stahl, Physician Assistant in Gynecologic Oncology and Clinical Instructor, Dr. Elizabeth Watson, Assistant Professor of Radiology, and Dr. Krista Evans, Assistant Professor of Surgery. Thank you, panel. I will turn it over to Dr. Krista Evans to get us started.
Hello all, thank you for joining us. I thought that we'd start out the talk about what screening means and who would be screened. And then we'll get into some of the Vermont data, as well as my part will be talking about colorectal cancer screening. So screening is defined as trying to find cancer or some disease process in the average risk population. I actually think it's easier to explain who should be screened by who shouldn't be screened. So next slide. Those who shouldn't be screened are called higher risk surveillance population or diagnostic population. These people are higher than average risk of having the disease you're screening for. So in colon and rectal cancer, that would be someone with a family or personal history of cancer or a precancer like a polyp or breast mass in breast cancer. Someone with a medical condition that puts them at higher risk for the disease. And then someone with symptoms would be considered a diagnostic evaluation. Next slide, please. The goals of screening are very straightforward. We're trying to detect cancer, improve the number of life years gained due to the detection of cancer, as well as decrease the cancer-related mortality. And what we really want to avoid is a screening test on average risk patients that's very uncomfortable, very time-consuming, or takes away from the person's quality of life. Next slide, please. Thank you to the Vermont Department of Health for sharing their data with us. The last time they collected data on causes of death in Vermont, they noted that malignant disease or cancers was actually the leading cause of death in Vermont adults. This passed heart and respiratory disease in 2007. Next slide, please. In females, the leading type of cancer is breast, followed by lung, followed by colon and rectum, uterus, melanoma, other skin cancers, and then all other sites of cancers, more rare cancers. The leading cause of cancer death, though, is lung cancer, followed by breast, and then colon and rectum. Next slide, please. This is a really cool slide in that it shows when cancers are detected in our Vermont population. So the green bar is saying that this number of cancers were diagnosed when it had already spread distantly. Red bars are for regional disease at diagnosis, blue for localized, and purple for a pre-cancer diagnosis. So what you can see is across the board, we're doing pretty well at detecting cancers fairly early when they're still treatable. Next slide, please. So let's get to colon and rectal cancer. I think when people come into my office or their primary care's office, they have a lot of expectations about what screening for colon and rectal cancer is. And what I'd like to talk about today are the different ways we can do this. Some ways are more palatable to some people and other ways are less. So it's reasonable to have a discussion about all the different ways. Next slide, please. And the most important thing to remember is that people who get screened for colon and rectal cancer, their disease is found earlier. And the earlier we find disease, the more survivable it is. So we have very good survival rates for our colon and rectal cancers, even up to stage 3. And we even have some new treatments in stage 4 cancer that has led to longer term survival. Next slide, please. In Vermont, we are actually doing better than the average state in terms of our colon and rectal cancer screening. Our goal for 2020 was to get to 70% of adults of the age to be undergoing colon and rectal cancer screening. And we're better than that. We're at 72%, not meaning that that's perfect. We have room to grow, but we're doing pretty well. I have to say, while I talk often about stool and farts and things like that, a lot of people find this to be a very taboo subject. So it's something that it's important to become kind of common to talk about so that it is less embarrassing for people to have their screening and ask questions about it. Next slide, please. So the United States Preventive Service Task Force made recommendations for who should be screened, at what ages should we start it. So in general, people aged 50 to 75 should be undergoing colorectal cancer screening. I know a lot of you have seen data about starting at age 45. And while we are seeing colon and rectal cancer cases increase in people age 40 to 50, the numbers are still about 20 times less than that of people over 50. So our different guidelines are still considering whether it makes sense to start screening at age 45, whether the cost makes sense or disease found is actually going to turn into a cancer if we found a polyp. And it's very complicated, I will say, and something that's very worthwhile having a discussion with your primary care doctor or surgeon, but it's not that straightforward at this point. Adults who've never had a polyp or symptoms or something that makes them higher risk should complete screening around age 85. Next slide, please. There's 2 different ways to screen. One is stool-based and one is direct visualization. So with stool-based, we're either trying to pick out blood or cancer particles or genes within the stool. With direct visualization, we're actually looking for cancers, inflammation, polyps. And with the direct visualization, many of these means allow us to actually take things out with the scope, which could prevent you from having a cancer. And we'll talk about each of these. Next slide, please. So the fecal occult blood test is our oldest type of screening method. This is the one where the doctor gives you the cards and you submit 3 separate stools as sort of a smear. They develop it with a chemical, and what they're looking for is something called guaiac in the stool. Guaiac is a particle of blood, and it could be seen in dietary meats. It could be seen if you have a little bit of bleeding from your upper bowel, like your stomach, because you have an ulcer. So before you have one of these tests performed, you have to be very restrictive in your diet. You have to be careful about what medications you're taking. I would say that people are not great at doing this, but it works very well for many people, especially people who couldn't take a time off for colonoscopy. And it's very inexpensive to complete, which is really nice. It's also well covered. In our studies where people are entering a research study because they're motivated to learn more, we still only have about 38 to 60% of those patients who actually complete the testing appropriately. Next slide, please. The fecal immunochemical testing we have rolled out in Vermont. We started doing this about 2 to 3 years back. And this is a test where, again, you're collecting stool and you're actually sending it off to a lab in Mayo Clinic to evaluate it. Usually that's 2 consecutive samples. Thankfully, you don't have to do all the dietary restriction with it. And what this looks for is heme in the blood, which is a part of the human blood cell. So it wouldn't pick up on some of the dietary things that you might be taking that the fecal occult blood test would pick up on. If either of these are positive, the next thing to do would be the colonoscopy, which would be the definitive evaluation. I think our providers had initially been nervous about recommending this test because it was a send-out test and they were unsure how easy it would be to get the results and then call a patient back if it were positive. But we found that it's worked very well for people who are willing to do this. Next slide, please. The fecal DNA test. This is the one that you're seeing advertised on TV all the time. The thought is that the colon is constantly shedding cells into the stool and that we can pick up on DNA material within the stool. Often this one's combined with the fecal immunochemical test, which we just spoke about, that picks up the heme or the blood in the stool too. This is done every 1 to 3 years. There is a higher rate of false positives, meaning 1 in 10 people who have a positive Cologuard and undergo colonoscopy, nothing is found that's a cancer. So while I think that it's going to be really great to use, it has not been fully supported by all of our preventive service task forces. Next slide, please. CT colonography. So this is what patients will come in and say, hey, what about that virtual colonoscopy? Can't I have that done? This is pretty cool. This is a CT scan. What you need to know is that you still need to undergo a preparation before it because the inside of your colon needs to still be very clean. Anything adherent, like a small little amount of stool, could look like a polyp. So we want you to be very clean. When they do the CT colonography, they actually inflate your colon with air too. And so patients need to understand that it is still a little crampy because that gas can be crampy in your belly. So it's not completely painless, but it works very well too. We do not have this at UVM Medical Center, but Dartmouth Hitchcock does have this. You have to have a very good radiology team that's invested in evaluating this, and oftentimes they set it up so if you have a CT colonography that's positive in the morning, you would have a colonoscopy in the afternoon. So you really want a good system in place for following up the positive tests, especially since you've already done a big prep for this. The couple of drawbacks to it is that it is a radiation exposure. It wouldn't remove a polyp if you had one. You'd have to have the colonoscopy still. And then we find a lot of things outside the colon that we wouldn't have necessarily found or knew what to do because we're doing a CT scan and we see the rest of the body. So sometimes we find a little fluid-filled cyst on the liver that we're uncertain of, and that may lead to more evaluations with more testing. So certainly something to consider. Next, please. A sigmoidoscopy is looking at the left side of your colon. This is a test where you would have to do an enema beforehand, and usually that clears you out well enough, and it can be done in the office. I do these frequently in my office, but more so for my patients that had cancer that I'm following. The reason that a left-sided scope that only goes from the anus to the splenic flexure is helpful is that the majority of polyps are found on the left side. And if you found a polyp or something on the left side, you should then follow it with a real colonoscopy. The nice thing with this is that you don't need sedation for it. So you can drive yourself to the office for the procedure, and then you could even work that same day if you chose to. Next, please. And then colonoscopy is considered our gold standard. This is where you do the prep to clean out the inside of the colon. You come into the hospital or procedure center. You have an IV so that you can get sedation if you so choose. And we look at the entire colon from anus all the way over to cecum, which is over to the right side of the colon. And if we see a polyp, such as the two you can see to the side here, we can take those out. If we saw a cancer, we can biopsy them and mark them for ourselves. The biggest drawback is that it requires a full preparation, which is pretty time consuming. Many patients have sedation for this, so typically you need the day off from work and you need a driver, which means they'd need time off from work. And then there is a very small, very rare risk of complications with this. All right, next slide, please. And this is just showing an up-close picture of some of the polyps we can remove. Next slide, please. The good news is, next slide. So this is what the U.S. Preventive Task Force submits every 5 to 10 years that tells us about how good our screening is. The benefit is that each of these screening tests I have talked about today has the same number of life years gained per 1,000 individuals screened, meaning it is equivalent at preventing cancer-related morbidity. Next slide, please. Next slide. And it also, each of these tests also prevent the same number of cancer-related deaths. Next slide, please. So you're probably asking yourself, what's the best test for me in particular? If you're an average risk adult, it's the one that you think you can do with the least amount of changes to your lifestyle, because we just want it to get done. Next slide. So now we're going to move on to Stephanie Stahl.
Thank you, Krista. Hi, I'm Stephanie Stahl. I'm a physician assistant in gynecology and gynecologic oncology here at UVM Medical Center, and I'll take the next bit of time to talk to you about screening for gynecologic cancers. In a way, I kind of think about the annual GYN exam. We do lots of things there. We make sure that you're meeting all of your screening for other health issues, but one thing I think about is how am I screening for different types of cancers. The Pap smear is the one that we all know about, and that is a screening test for cervical cancer, but it's not a screening test for the other gynecologic cancers, meaning those criteria that Dr. Evans talked about, something that we use for the average risk person without symptoms. So when I'm seeing somebody for their annual GYN exam, I'm also doing other things that I'm asking you about symptoms that may make me concerned about other gynecologic cancers. I'm doing an exam to look for other signs of cancer. I'm counseling you at the end of what kind of warning signs to watch out for. And I'm asking about family history. Are there risk factors that might make me think that you meet criteria for additional screening? And these are some things that we'll talk about in the next few minutes. Next slide, please. This cartoon illustrates the different types of gynecologic cancers. The majority of this talk will focus on Pap smears and cervical cancer because it is such a successful story in screening, and it's the one true screening test that we have. But as you see, endometrial cancer is the most common cancer that we see. We don't have a routine screening test for that, but we do have symptoms that you can watch out for that we'll talk about later. Following that is ovarian cancer, and then vulvar and vaginal cancers in terms of others. Next slide, please. So starting with cervical cancer, this is really a success in screening. Some numbers that we would give is that it's the 11th most common of all cancers in women in the United States, with those numbers of diagnoses and predicted deaths in 2020, but the third most common of those 5 gynecologic cancers. One thing to really notice is that in parts of the world that does not have good Pap smear screening, it's the second most common cause of all cancers. So with good Pap smear screening, we can really make it a less frequent disease. It's most commonly diagnosed between the ages of 35 to 40, and in the upcoming slides, we'll talk a little bit more about why that timing is the case. Very rare in younger women, less than the age of 21, and also rare in women over the age of 65. These numbers help explain how our guidelines tell us the frequency to do Pap smears, when to start them, and when to stop them. And is truly most commonly diagnosed in women who have not had adequate screening or good follow-up. An important thing to understand about cervical cancer is that we know that it's caused by a virus, human papilloma virus, and that with routine screening and a vaccination, it can truly be preventable. The vaccine came out in the early 2000s. You may have heard of this. It is a vaccine that helps fight certain what we call strains of the virus. There are many strains, some of which are what we call high risk. And those high risk strains are the type of infection that can ultimately lead to precancers or cancers of the cervix. Next slide, please. So human papillomavirus, or HPV, is again the virus that we know is associated with the vast majority of cervical cancers. It's a very common sexually transmitted infection with somewhat alarming statistics that you'll see there. We estimate that many women who have been sexually active will have seen this virus at some point. But the important thing is that the majority of women do clear it without it having an effect on their pap smear or leading to cervical cancer. There are risk factors for that, as listed there: early onset of sexual activity, having had multiple partners, immunosuppression, and a history of other types of infections. And again, those high-risk strains have been detected in upwards of close to 100% of cervical cancers. In the majority of cases, the infection is transient and won't cause problems, but when it persists, it can lead to precancers of the cervix and cancers. And again, the vaccines are available to help prevent that infection. Currently approved starting at the age of 11 for young girls and boys, and formerly was approved up to the age of 26, now approved up to the age of 45. Next slide, please. This talks about the incidence of HPV-associated cancers in Vermont. HPV is associated not only with cervical cancer, but others as well. And this shows that the incidence in Vermont is across the board pretty on par with the rest of the country. And this is again including other cancers that are also caused by HPV. Next slide, please. This slide shows us that we're doing pretty well in terms of HPV vaccination rates. These are statistics from 2016, and more recent estimates show that approximately 65% of teenage females have completed the series that'll help protect them against HPV in the future. Next slide, please. So moving on to the screening test that we do for cervical cancer, as we know, it's a pap smear. This was developed in the 1950s by Dr. Papilloma. These are the instruments that we use. So of those, the one that we usually use in the office is that broom and that cyto brush, if you see that. And we currently use the liquid-based cytology that's mentioned on the left there. As most women have experienced, this is done in the office where a speculum is placed. And then we take a small sample of the cells that are at the opening of the cervix with that broom and that brush and send them to the lab. Next slide, please. This is sort of a busy cartoon that helps explains what the lab sees when they get it, but the main thing I'd like you to look at is from left to right. So on the left, that shows what a normal cells would look like. They're flat and they're what we call differentiated. They look normal. And as we go from left to right, that shows more abnormal cells. And on the bottom right, that shows a true cancer. So when I, as your PA, do your pap smear, I receive a result that'll tell me that your pap smear is normal, or perhaps the pap smear is a low grade or a high grade. And that allows us then to move forward and take steps to prevent that from turning into a cancer. That usually means we would bring you back for a procedure where we take a closer look at the cervix with sort of a big magnifying glass and perhaps take biopsies to get a better sample. And the important thing about this screening is that if we see those precancerous changes, we can act on that. We can treat the cervix to prevent that from developing into a true cancer. Next slide, please. So when should women have a pap smear? So based on some of the numbers that we talked about before as to who is most at risk for the virus and who is most at risk for cervical cancer, the American Society for Colposcopy and Cervical Pathology gives us guidelines that we initiate doing pap smears at the age of 21. When I order a pap smear, I can choose two things. One is to do only the pap smear, or the other is to also test for the virus. Between the ages of 20 to 29, our guidelines tell us to do a pap test every 3 years and not to look for that virus except under certain circumstances, such as if the pap smear is indeterminate. The reason for that is we know that in that population, if the virus were there, we'll typically clear it before it makes those changes. And so the virus wouldn't really change what we would do with that information. Keeping in mind that these guidelines change quite frequently. So in upcoming years, we may learn that doing that virus test earlier may give us some good information. Between the ages of 30 to 65, we can do two things. We can do a pap smear every 3 years as we do before, or we can also test for the virus. If we test for HPV and that is not there, we feel comfortable that we can do a pap smear every 5 years. If we test for it and we find that virus is there, that then allows us that we should do pap smears more frequently or do some other testing to screen for precancerous cells on the cervix. And then based on, again, that we know that that main risk factor for developing cervical cancer is exposure to the virus, after the age of 65, if women have had routine screening and at least 2 normal pap smears with a negative HPV or 3 normal pap smears in the past 10 years, we feel very comfortable that we can cease further pap smears at that time. Next slide, please. We do have women who are at high risk that would have different guidelines. So if you or somebody that you know were to fall under these categories, then that's a conversation to have with their provider. Those would be women who are HPV positive, women who are immunosuppressed due to medical conditions or being on immunosuppressive drugs, or women who have been exposed to diethylstilbestrol, DES, when their mothers were pregnant with them. That was a medication that was prescribed up to, from the 1940s to 1971 to help prevent miscarriage and premature labor. And those women would have more frequent pap smears and also not stop doing pap smears. Next slide, please. And this slide shows that we do pretty well in terms of cervical cancer screening. So the national pap test rate was 82%, and in Vermont, the rate in 2014 is 86%. So we're doing pretty well here in Vermont in terms of pap smear screening. Next slide, please. So after talking about cervical cancer, again, just want to briefly talk about the other gynecologic cancers that we see more frequently. Again, we don't have a routine screening test for asymptomatic women, but what I think is important is for all women to recognize those symptoms that may lead to those cancers. Keeping in mind that these are common frequent symptoms that many times represent something else. And so certainly if you have these symptoms, it doesn't mean that you should be worried that it represents a cancer, but it does indicate it's a reason to see your gynecologist or otherwise seek evaluation for that. Next slide, please. Endometrial cancer, which is the cancer of the lining of the uterus, is the most common cancer that we see here in Vermont. And again, there's no screening test for average women, but in the majority of women who are diagnosed with this, they present with a symptom which is unusual. And that is either postmenopausal bleeding or a change in their premenopausal bleeding pattern, whether that's bleeding more frequently or bleeding for a longer amount of time. Again, symptoms that can be caused by other reasons, but definitely a reason to seek evaluation should you have those symptoms. We do have some women who meet a high risk population, and those are women that have what is called Lynch syndrome. That's something that can be found in families where there are women or other family members with colon and endometrial cancer. And if based on family history and genetic testing leads to that, we do offer high risk screening for that population. Next slide, please. Second is ovarian cancer. September is Ovarian Cancer Awareness Month, and we have that slogan which says, "The symptoms whisper, so listen." Again, we don't have a screening test for average risk women, but we do have what's called the Ovarian Cancer Symptom Index. And that means that most women who we talk with who have been diagnosed with ovarian cancer can reflect back and say that for the past several months, they would have had these following symptoms: new or different and persistent abdominal or pelvic pain or pressure, bloating, increased abdominal girth, urinary symptoms such as frequency, or gastrointestinal symptoms such as nausea or feeling full sooner. The key is that these symptoms are new, different, and persistent. And again, can be caused by many different things, but something to be very aware of, that should you have those symptoms, it is cause to bring them to your provider's attention. Again, we have a high-risk population, which are women who have a strong family history of ovary or breast cancer and test for particular genetic changes. And for those women, we do offer high-risk screening. If that were to apply to you or somebody you know, then we can certainly talk about those screenings and risk factors. Next slide, please. And the last one that I'll bring up is cancer of the vulva being the skin on the outside of the genital area. Symptoms of that include persistent vulvar itching, pain, new or different bumps or lesions, as it says to the side, basically just being aware that that is something that can happen, and to know that should you have those symptoms, there's something to bring to your doctor's attention. Again, saying that those can be caused by many different things, such as the common yeast infection or irritation from soaps or even things like eczema, but very important that should somebody have those symptoms and it's not explained by another reason, to seek attention. Next slide. And that's the end of my talk. So I'll invite Dr. Watson to tell us about breast cancer screening. Thank you.
Hello, everybody. My name is Dr. Elizabeth Watson. I'm one of the breast imagers here at the University of Vermont, and we're going to be talking about breast cancer screening. So unfortunately, breast cancer is a very prevalent disease. All in, about 1 in 8 women in the United States will be diagnosed with breast cancer in their lifetime. And that does not take into account those women who have a high genetic predisposition, such as a genetic mutation or family history. This is all women, 1 in 8 will be diagnosed with breast cancer. So it's certainly a disease process that we do tend to see. It's quite frequent. Next slide, please. We do know based on data that over time, the number of breast cancer cases does increase with age. As you can see on the graph in the right side of my screen, that as women do age, the number of cases continue to increase. And you can see that by the elevation in the graph. Until women usually are about 75, at which time the number of cases really does plateau. And then about 80 and above, the number of cases does tend to decrease. But you can see the steadily increase in number of cases as women age. So that's certainly something to remember. Next slide, please. So the purpose of breast cancer screening is, and specifically screening mammography, is to detect a large percentage of breast cancers before they're clinically palpable, before we can feel them. We want to be diagnosing masses when they're about 1 centimeter in size, as you can see, the size of basically a pea. We don't want to be diagnosing breast cancers when they're 5 centimeters, as you can see, the size of a lemon or a lime. That certainly, we want to be diagnosing them earlier. Well, when they're smaller in size, they're an earlier stage, and they're more likely to be curable at that stage. Next slide, please. So according to data that we have over the last couple of decades, the SEER data, we know that the mortality rates or the death rates from breast cancer before 1990 were very, very stable for about 50 years. They really weren't changing. But then what we saw in about 1990 until 2007, the mortality rates from breast cancer dropped quite a bit. They dropped about 31%, which is pretty significant. And the reason that we think that the mortality rates from breast cancer dropped so steadily starting in about 1990 is that in the 1980s, breast cancer screening, like mammography, really came to the forefront and started to be used by more and more women. And so we were able to see the impact on breast cancer mortality a few years later, starting in 1990. And so we really attribute that large decrease in mortality rate from breast cancer to screening mammography and its use among women. So it's a quite successful screening study. Next slide, please. So how are we doing in our state? How are we doing in Vermont? Well, nationally, we know that the breast cancer screening rate among women, when we look at women who are aged 50 to 74, in 2016 was about 78%. And we're doing pretty well compared to that national average. In 2016, our national rate of screening usage, screening mammography, was 79%. So we actually beat it by 1 percentage point, but that's about the same as the national average. And you can see the breakdown based on county in the map provided. They're all pretty similar to the overall state average. Next slide, please. And when we look at the rate of advanced stage breast cancer rates, we're actually doing pretty well too. In Vermont, the incidence rate of advanced stage breast cancers in women who are 50 and above is about 94.4 per 100,000 women. And when we look at the national rate of advanced stage breast cancers, the US rate is about 105.5 and per 100,000. So we beat it by a fair amount. So we're actually diagnosing fewer women with advanced staged breast cancer, which makes us think that we're finding breast cancer earlier and we're able to treat it before it gets to the advanced stage. And you can see the breakdown by county. Most of the counties are very similar to the overall Vermont, the Vermont rate. And we consider ourselves to be doing pretty well in this regard. Next slide, please. So now I'm going to change gears a little bit and talk about all the different types of screening studies that we have for breast cancer. Probably the most popular, the most common that people know about, and the most heavily utilized is screening mammography. And currently, 3D mammography or tomosynthesis is really taking over and becoming the standard of care for women to diagnose breast cancer and to find it early, like we talked about before. And so as you can see in this image, this is a woman having a screening mammogram, which is performed by a technologist. The breast is in compression. And these are the images that are created that are read by the radiologist on the right side of the screen. From the patient perspective, having a tomosynthesis done feels very much like the standard mammograms you've had many, many years before. However, what's different is that as radiologists, we're actually able to look at slices of the breast and very, very carefully look through the breast tissue in a way that we couldn't before with standard mammography. And this allows us to actually improve our cancer detection rate. So we're actually finding more breast cancers and we're having fewer false positives, meaning that we call fewer women back with false positive results. So it's been a great change, a great advancement in screening mammography, and which is why it's really become the mainstay and become the standard of care throughout the country. Next slide, please. Okay, so the next type of screening study that I wanted to talk about is something called screening breast ultrasound. And screening breast ultrasound is now becoming more popular as we're understanding a little bit more about the impact of breast density on screening mammography. And those women who are told that they do have dense breasts could subsequently receive screening breast ultrasound. And what that is, there's two different types. This is the first type, as you can see, being done on the left side of the screen here, where an ultrasound technologist who's trained in ultrasound is evaluating a woman's breasts everywhere throughout both breasts in order to find any masses or areas of concern. And we know that studies were done on screening breast ultrasound, and out of every 1,000 women who have dense breast tissue and have a negative mammogram, we find an additional 3 to 4 breast cancers per 1,000 women. So those are 3 to 4 cancers that are mammographically occult, were not detected on mammography, but cancers that we're able to find with screening breast ultrasound. So that's certainly something, a great victory in the screening world, that we're able to find cancers that were not found before. However, we know that in order to diagnose those 3 to 4 per 1,000 cancers, we are calling back a lot more women and having to do a lot more biopsies as a result. So there is the downside of the false positivity that we're seeing with screening breast ultrasound. So there are two types of screening breast ultrasound. The first is this, which is a handheld, where an ultrasound technologist is actually performing the image herself. And the other type is on the next slide, if you could advance, please. And the next type of screening breast ultrasound is actually called automated screening breast ultrasound, or ABIS for short. And this is a technology that we have recently started using over the last couple of years here at University of Vermont Medical Center, and also through, I think there are other centers also within the state who are using it, and certainly across the country. And what this is actually a screening breast ultrasound that's performed by a machine. So we have the patient come in and lie on her back in the same way as the handheld screen, but this time a technologist comes in and places the computer, the machine, on the woman's breast, and the machine actually scans itself. And creates thousands of images, which are sent to the radiologist, and we review all of these images in order to look through all areas of the woman's breast and to detect any cancers. And so we are currently using this at our medical center here, as well as the handheld screening breast ultrasounds. Next slide, please. Okay, and so now I want to talk a little bit about the third type of screening study that we do to look for breast cancer, and that's called screening breast MRI. And this is really a type of study that's reserved for those women who are at a higher risk of breast cancer. And it does involve having an IV placed and some gadolinium or dye injected into your veins. And what we look for are areas that light up in the breast. We know that normally there are many areas that light up in the breast which are completely normal and benign. But what we look for as radiologists is areas that enhance in a different way, and a way that's suspicious to us. And when we see that, we raise some red flags for concerns for breast cancer, and we may end up doing ultrasounds or subsequent biopsies as a result. But because this study does involve an IV and some dye, it is reserved for those women who seem to be at a higher risk. Next slide, please. Okay, so how should I get screened for breast cancer? I'm sure that's after we've reviewed all the different studies, everybody sort of asks, okay, well, this is great, but what should I do? Next slide, please. Well, the American College of Radiology and the Society of Breast Imaging have recommended that all women, especially those who are African American or of Ashkenazi Jewish descent, should be evaluated for breast cancer risk at no later than age 30. So those women who are felt to be high risk can be identified and can be advised which sorts of screening modalities they should consider, whether that's just screening mammography or whether they should undergo supplemental screening as a result of their risk. Next slide, please. And so what I'm going to present right now are what we consider the average risk screening recommendations. If you could advance again, please. And these are recommendations that are meant to encompass about 75% of those women who are considered, 75% of the women who do develop breast cancer are considered to be average risk. So these average risk recommendations account for the vast majority of those women out there who are getting diagnosed. Next slide, please. So we recommend that screening mammography start at the age of 40, that it occur annually, and there's no definite age that we recommend screening should stop. However, we know that if a woman is really not going to act on the results of the study, then we usually say that maybe it's time to stop screening. And these are recommendations that are supported by the American College of Radiology, the Society of Breast Imaging, the Society of Breast Surgeons, as well as the National Comprehensive Cancer Network. Next slide, please. However, I wanted to include that there are many different screening recommendations at the current time for screening mammography. It is a very, very confusing time for women, and we understand that. There are many different organizations who are supporting various recommendations, and they're all somewhat valid in their own way, depending on certain strengths and weaknesses. And so what we stress to women is that they need to have a conversation with their primary care doctor or their referring provider in order to figure out which screening modality and which recommendations are best for them. Next slide, please. Okay, and so when you do have a mammogram, we are going to talk, as radiologists, going to talk about breast density. We'll classify your mammogram using a 4-level density scale. As you can see, all the way on the left side of the image is a breast that's almost entirely fatty, and you can see it's very dark, it's very fatty, not a lot of breast tissue. It's an easier mammogram to read. When you look at all the way on the right side of this screen, you'll see what we consider an extremely dense breast. And this is a breast that has a lot more fibroglandular tissue, can be a little bit more difficult. Advance, please. And, there we go. And so the two top categories, the heterogeneously dense and extremely dense categories, are those women who we consider to have dense breast tissue. And so these are the women that we sort of set aside and say, in addition to the standard mammogram, you may want to consider having that additional screening study, a supplemental screening study, which could be ultrasound, it could be MRI. Next slide, please. So who are those women who are considered to be high risk? Those are women who may have a genetic mutation. So that may be the BRCA1, BRCA2 genetic mutation, although we know that there's a whole host of genetic mutations in addition to those as well. It also may be a first degree untested relative of somebody who has a known genetic mutation. Those women who've had a family history of having breast cancer in their family, those women who've had history of chest or mantle radiation therapy before the age of 30, those women who've had a personal history of breast cancer, so they've been diagnosed at some point in their life, and they may have had prior biopsy where things such as atypia or lobular neoplasia may have been diagnosed, which puts puts them at a somewhat increased risk of having future breast cancer diagnosis. And I also included dense breast tissue, as those women are at a slightly increased risk of getting breast cancer for a couple of reasons. Okay, so if you are considered to be high risk, that means that you have a calculated lifetime risk of about 20% or greater of getting a breast cancer diagnosis in your lifetime. Advance, please. Okay, and so for those women who have a genetic-based risk, so this is either the BRCA1 or 2 genetic mutation, in addition to multiple other genetic mutations, we do recommend that screening mammography start at the age of 30, with MRI to start at the age of 25 to 30. Advance, please. If you've had a history of chest radiation before the age of 30, we recommend screening mammography to start at the age of 25 or 8 years after radiation, whichever is later. And screening MRI should start at the age of 25 to 30. Next, advance, please. If you've had a personal history of breast cancer or these atypias, which we just sort of mentioned, we recommend that annual screening mammography should begin at the time of diagnosis. Advance, please. If you have a family history of breast cancer, we recommend starting mammography screening about 10 years before your earliest relative, not before the age of 25 and not after the age of 40. Next slide, please. And for those women who've been diagnosed with breast cancer and do actually have dense breast tissue, or those who are diagnosed before the age of 50, we do definitely recommend getting annual breast MRI in addition to mammography. Many women choose to actually to stagger them by 6 months. So to get an MRI, 6 months later, get a mammogram, 6 months later, get an MRI. So each the mammogram and the MRI are done annually, but somebody is looking every 6 months. And so that's a very popular plan for surveillance. Next slide. Great. So at this point, we've sort of reviewed the screening guidelines for colorectal cancer, for gynecologic cancers, as well as breast cancer. So I hope you enjoyed our talk. I hope it was helpful for all of you. We're happy to take questions if there should be any from our participants at this time. Okay, I'm not seeing any questions yet. Okay. Okay, looks like we just had one. Okay. The question is, if I had a breast cancer, does screening change for me? If you've been diagnosed with a breast cancer, it sort of depends. If you've been diagnosed with a breast cancer, then what we would recommend is that you continue screening. Usually what we recommend is once your treatment has stopped, once you're done treatment, we recommend you return for your screening mammogram with 1 year after your most recent. And then you may want to consider, if you have dense breast tissue, you may want to consider having another screening study as well in addition to a mammogram. So if you do have dense breast tissue, then it would be something to consider having ultrasound or MRI based on your calculated risk. So that's certainly something, if you were concerned, to talk to your doctor about, and a risk assessment can be done to figure out whether an additional screening modality would work for you. Okay. So I have another question here. If my dad had a polyp removed, should I start screening for colorectal sooner than 90? I might actually direct that one to Dr. Evans.
Perfect. So if your dad had a polyp and he was younger than age 60, then we would recommend you start screening earlier. And screening in your instance, because you're considered higher risk, would be colonoscopy. And typically that would be repeated on a 5-year basis as opposed to 10 years, because we know you are more so at risk. If your dad's polyp was after age 60, we assume that a good number of patients, probably in the 40%, are going to have polyps in their lifetime, and your risk of polyps increases as you age. So if it happened after 60, it doesn't necessarily confer a higher risk to you.
Okay, so we have another question here. Where does a PET scan fit? I'm not sure, so I can start a little bit. In terms of breast cancer screening, we don't typically recommend that PET scans be done as a screening study. PET scans are a type of nuclear medicine imaging, which we really only recommend once a diagnosis of cancer is made. Down the line, if the oncologist is worried about distant spread of disease or metastatic disease, that's typically when a PET scan is used. It's not used as a screening study. And I'm assuming that works for colorectal and gynecologic images as screening as well.
Agreed.
Perfect. Okay, good. Okay. Are there any other questions? Oh, here we go. Can you speak to the difficulty of screening for lobular breast cancer? Absolutely. This type of breast cancer often does not appear on mammography. So absolutely. So screening for lobular breast cancers is a difficult thing. Oftentimes we are able to see lobular breast cancers on mammography, but you're absolutely right, it's difficult. There are some that we absolutely can't see. And so that's why, you know, if a woman does have dense breast tissue, then the additional screening modalities are really helpful in the setting of trying to screen for malignancies such as a lobular breast cancer. We can often see lobular breast cancers on ultrasound and on MRI, although again, it's very difficult. This remains a very difficult diagnosis, but certainly one that I would consider an additional study to evaluate in the setting of dense breast tissue. Okay, so we have another question. I had stage 3 colon cancer and I had a polyp before age 60. What age should my children be tested? So I might ask Krista for that one.
Yeah, so the first is I had stage 3 colon cancer 10 years ago with no follow-up. Should I be doing something? So oftentimes after having a colon cancer, we follow very closely. Every 3 to 6 months for the first 2 years, you're having an exam, a physical exam. Yearly, you're getting CT scans of the chest, abdomen, pelvis. And then at the first year out from your surgery, you would be undergoing a colonoscopy, then 3 years, then 5 years, and then every 5 years from thereafter. So I think it's an incredibly great sign that you're at 10 years, you're still doing well. Most colon cancers recur within the first 2 years. So I suspect things will be good, but I do think that if you're healthy enough to undergo colonoscopy and CT scans, that would be a reasonable way to start. Next question from our audience is, my father had a colon cancer and I had a polyp before age 60. What age should my children be tested? So your children should start their colonoscopies at age 40. So we say either 10 years before the first degree relative had a polyp or a cancer, or age 40, whichever comes first. So in their instance, they should start their colonoscopy at age 40.
Okay, so I'm not seeing any more questions. I hope that was helpful for everybody. Thank you so much for your attention, and we greatly appreciate it. Thank you.